Fantastic. Good morning, Young, and of course, good morning, everyone. It gives me great pleasure to introduce Dr. Younghoon Kwon this morning. Young joined us 2 years ago from Virginia to serve as the director of our CCU at Harborview. Young's a cardiologist with training both sleep and critical care. And this unique background places him in an ideal position to explore the intersection of these three fields in both his research as well as his clinical practice. Young's research focuses on exploring novel ways to evaluate and treat sleep apnea. He's been prolific with over 80 peer-reviewed publications. Young's work is currently supported by several NIH grants. He's the PI of 3 awards studying physiologic coupling and sleep and cardiovascular disease. He's also exploring novel ways to evaluate and treat sleep apnea. And the topic he'll discuss today is related to his passion for improving safety and quality of care of patients in acute care settings through better recognition and monitoring of sleep disordered breathing. Again, welcome, Young. Looking forward to your talk. Please go ahead.
Thank you. Thank you very much, Nona, for a kind introduction, and good morning, everyone. So my topic today is entitled, Is Your Sleep Breathing Restful and Sufficient to Your Heart? No relevant disclosure. My objectives are to understand the adverse cardiovascular and health consequences of sleep disorder breathing, and I'll also touch on obesity hypoventilation syndrome, which is somewhat underrated within this concept of sleep disorder breathing. Will help you understand, recognize obesity hypoventilation syndrome as a major health risk. And we'll touch briefly on new paradigms for sleep apnea evaluation and therapy. So some clarification on nomenclature. When we refer to sleep disorder breathing, we typically refer to OSA because that's the common type of, most common type of sleep disorder breathing. When we call OSA as a diagnosis, what we mean by that is that majority of respiratory events occurring in sleep are obstructive in nature, whereas central sleep apnea refers to a situation where majority of respiratory events in sleep are scored as central. The reason why I mention this is, in reality, you frequently see a mixture of OSA and CSA events at an individual level. Sleep disorder breathing as a whole includes OSA, CSA, plus minus Cheyne-Stokes respiration that you're very familiar with in heart failure. Also sleep hypoxemia, for example, someone has a lung disease, they may manifest hypoxemia, but without necessarily any obstructive sleep apnea. That is also part of sleep disorder breathing. Sleep hypoventilation and topic that I'll briefly touch on, obesity hypoventilation syndrome. These are also important components of sleep disorder breathing. So just give you some example of individual OSA and CSA event. The picture on the left points to repetitive episodes of central apnea, which can be represented as won't breathe. So your brain basically forgets to tell you to breathe. And on the right is obstructive apnea. That's much more common in people in community. This is described as can't breathe. You would like to breathe, but you cannot breathe because of upper airway compromise. Just a quick review of pathophysiology. Due to obstructive mechanism, there is various downstream physiological effects. So one thing that's very obvious is that your oxygen will decrease and your carbon dioxide level will increase. That has some implications in terms of pulmonary vascular resistance and RV afterload. More from the left side, with this event, typically arousal is accompanied, and arousal and obstructive breathing together lead to acute sympathetic activity surge that can be manifested as an increase in blood pressure. These will be resulting in acute increase in left ventricular afterload. And with this type of Mueller-like maneuver, where you try to breathe against the obstruction, this will also result in negative intrathoracic pressure and excessive swing intrathoracic pressure that can also impact on this heart-lung interaction concept. I would like to review a few trials that have been, a couple of trials that have been recently done in the past decade. This one is most well-known randomized controlled trial. There are only a few, but this is one of them. It was a multi-site international trial done by Dr. McAvoy from Australia. Although a bulk of patients came from China, but the question was whether CPAP reduces cardiovascular events in people with cardiovascular disease. So this is a secondary prevention trial. The primary endpoint was composite cardiovascular death, acute MI, CVA, TIA, heart failure admission. Second endpoint was an individual component. Unfortunately, this was a negative study, and there's a lot of speculation about this. But yes, the bottom line is that there was no difference in terms of primary as well as secondary outcomes in this randomized controlled trial. This is another trial that came out a year prior to that study, from 2015, from Europe, where they asked the question whether adaptive servo-ventilation PAP, so it's a specialized bi-level or CPAP, so to speak, which is effective in resolving central sleep apnea and chain stroke respiration that's commonly noted in heart failure patients, whether that modality of therapy would improve outcome. And in this randomized controlled trial, not only this was a negative study in terms of primary endpoint, when they looked at the secondary endpoint component of primary endpoint, one of which was death from any cause, there was a signal that the group that was under intervention, ASV, actually had higher risk of death from any cause, and that primarily came from death from cardiovascular causes. Alerting the community that perhaps ASV, even though it's a very effective modality of therapy in suppressing central sleep apnea and chain stroke respiration, there is an evidence, at least from this trial, that there's evidence that this actually does harm on patients with heart failure. In parallel, there has been some new therapies that came out. This is from Remedy. This is Remedy system from Respicardia company, which has been recently sold to Zoll company, where they try to stimulate a phrenic nerve, and the purpose of that is to stimulate respiration, and so this can be applied to people who have, or patients who have central sleep apnea. Of course, that's very common in patients with heart failure, and their studies have shown that this does work and effective in reducing central sleep apnea. Long-term outcome is still under works, but it is an effective treatment in suppressing central sleep apnea, and currently FDA approved. I know some of us in our EP group expressed interest in implanting this device. There are a number of places that are implanting this device at this point. I'd like to move to a case. A 57-year-old man with a history of hypertension on medication with the recent episode of 3-minute atrial fibrillation during a screening colonoscopy. Loud snoring and apnea spells were noted during the procedure under moderate sedation. Afterwards, the patient was referred to cardiology office because of this paroxysmal new onset atrial fibrillation, possibly new onset. His BMI is 35. Otherwise, he's a very active man without any complaints. Event monitor was ordered, and this was not revealing in terms of AFib, but did show some episodes of SVT and PVC, PACs. 3 months later, he was alerted by his Apple Watch for irregular heart rhythm. He was referred to presenting himself to the urgent clinic where he had a 12-lead ECG that showed an atrial fibrillation with heart rate on the higher side. He was then referred to ER from the clinic where he showed persistent AFib despite IV metoprolol. He was admitted for possible TEE-guided BC cardioversion, and indeed he underwent TEE-guided cardioversion to stop the ongoing AFib with RVR. Now, with this, since this was intended for cardioversion, anesthesia was involved, and he was administered with propofol for deep sedation. Again, the operator and the anesthesia heard loud snoring, and there was some desaturation, despite the fact that he was on oxygen supplement. Of course, this improved with the proper open airway positioning of his head and neck by anesthesiology team. But due to ongoing cough and gag reflexes, some additional sedation had to be given. Blood pressure was now noted to be low compared to the baseline blood pressure. He had a capnography that also showed occasional apneic spells as demonstrated on the bottom right of the screen, and oxygen dipping frequently occurred. At one point, it required the bag valve mask ventilation to facilitate ventilation. Anyhow, eventually, decardioversion was performed and was successful. He was in the recovery unit. Again, snoring and intermittent desaturation was noted. Anesthesiology recommends that he be seen by a sleep specialist for sleep apnea evaluation. 2 weeks later, his smartwatch alerts again that he may be in irregular heart rhythm. So confirmed to be in AFib again. He was advised to go to sleep clinic. Also, he was referred to EP for a possible AFib ablation. Finally, he underwent sleep study, which showed severe obstructive sleep apnea. Now, of course, he denied any daytime sleepiness or any perception of poor quality of sleep. He thinks his sleep is good. Of course, this is despite the fact that he had markedly severe obstructive sleep apnea manifested from sleep study. So, as many of you know, in patients with atrial fibrillation, sleep apnea is very common. Now, this is not limited to patients with atrial fibrillation. Perhaps most of the patients that we see in cardiology, there's high burden of sleep apnea. That itself is not any hidden secret. But this meta-analysis highlights the fact that many patients with AFib have quite significant severe, moderate to severe sleep apnea. About 20 years ago from Mayo Clinic, they demonstrated that the recurrence of atrial fibrillation is much higher in patients with untreated obstructive sleep apnea after DC cardioversion. So it's very similar to our scenario, case one scenario, where in our case, patient's AFib recurred, and he certainly had an undiagnosed obstructive sleep apnea. So this observational study pointed to the fact that the sleep apnea might be an underlying etiology in triggering recurrence of AFib. Subsequently, a number of studies, as demonstrated in this meta-analysis, have shown that in this particular analysis, they looked at the recurrence of AFib in the after pulmonary vein isolation, so AFib ablation, where if you have untreated obstructive sleep apnea, the rate of recurrence of AFib is higher. In this study from Beth Israel in Boston, they demonstrated that in their single center experience, they demonstrated that among people who had pulmonary vein isolation procedure, people who are untreated with CPAP had much higher recurrence of atrial fibrillation versus those who are on CPAP therapy. This is a recent clinical trial, randomized clinical trial from Norway, Europe, where they assessed AFib burden in patients who were on CPAP versus no CPAP, so in a randomized controlled fashion. Their outcome of interest was AFib burden based on loop recorder. In this study, they did not find any significant difference in terms of AFib burden in group with CPAP versus without CPAP. And this was in a pre-ablation setting. Phase one of their project. Phase two, which we'll be looking at AFib burden in the post-ablation setting, is still ongoing. Some of the issues that we're dealing with this relationship between sleep apnea and atrial fibrillation is the fact that there are many shared risk factors between the two, namely confounders, especially obesity. Obesity is a very potent risk factor for atrial fibrillation, as all of you know. And so teasing this out is extremely challenging. In this study that was published in Heart Rhythm Journal in 2011, investigators showed that people with sleep apnea have an evidence of atrial remodeling, and they elegantly show this in this figures where they looked at the conduction velocity of the atrium as well as voltage of the atrium, and as you can see that there was a more significantly lower voltage in patients with OSA and slower conduction velocity in patients with OSA, alluding to the fact that there may be a remodeling process in patients with OSA in the atrium. Such a remodeling process may be manifested on the ECG as well, and in this study in MESA dataset, we looked at P-wave terminal force in V1 as well as maximal P-wave duration, which are some of the P-wave indices reflective of atrial remodeling. Here we show that people with a higher degree of obstructive sleep apnea have higher prevalence of abnormal P-wave terminal force, as well as maximal P-wave duration, but this P-wave terminal force was significant in all models. So this people with severe obstructive sleep apnea had much higher chance of normal P-wave terminal force in V1 as defined by 4,000 microvoltage milliseconds. So capitalizing on these facts and evidence, I am personally very interested in looking at the ECG signature during both daytime as well as nighttime, and use that as a tool to predict atrial fibrillation in people with obstructive sleep apnea. If we believe that people with sleep apnea have higher risk of atrial fibrillation, one question could be that among who with those with OSA will be at higher risk of atrial fibrillation. Using a deep learning technology, we're trying to design a study where we're looking at not only a daytime ECG, but also nighttime ECG that potentially show us some interaction between respiration and electrocardiographic activities. Using these two inputs, whether we can predict new onset atrial fibrillation. Of course, sleep apnea is probably one of the most important elements in this paradigm, but we also are interested in other aspects of sleep, such as sleep architecture. In this study, where Dr. Sina Garib, who is here in sleep department, we were interested in whether sleep architecture have any association with having an atrial fibrillation. In this cross-sectional study, we, for the first time, looked at the slow wave sleep distribution in atrial fibrillation. What we found was people who have lower amount of slow wave sleep. Slow wave sleep is basically a deep sleep or N3 sleep, which is considered a very good sleep stage. The lower amount of that, so if you have low quantity of this good sleep, slow wave sleep, you have higher chance of having atrial fibrillation. Of course, this was a cross-sectional study with some limitations. This study that was published in Heart Rhythm, in a way, kind of tried to unfold this in a prospective manner, using cardiovascular health study data. Subjective sleep of nighttime awakening complaint was associated with higher risk of incident atrial fibrillation, pointing to the fact that perhaps sleep quality is also an important element in its relationship with atrial fibrillation. Now let's talk about impact of sleep apnea in the peri-operative or procedural setting. People with OSA typically are obese, and that results in low lung reserve. People with OSA are known to have a tendency of difficult airway, namely difficult intubation, difficult ventilation. If you have both obesity and obstructive sleep apnea, you're more susceptible to developing hypoxemia and hypercapnia. We see this all the time in the ICU or in any acute care setting. This study, a MATS core study done by anesthesiology colleagues, demonstrated that patients with obstructive sleep apnea, with the diagnosis of obstructive sleep apnea, have higher complications of respiratory complications, as well as cardiovascular complications. In this study, they found that the ARDS, respiratory failure, is higher in people with sleep apnea. And they also have higher incidence of cardiac arrest and shock. Oftentimes, as you know, these acute respiratory failure are closely linked to incidence of cardiac arrest and shock because they have a very close interaction each other. In non-cardiac surgery setting, unrecognized OSA is also associated with increased risk of cardiovascular events. Here, you can see that people with a severe OSA have higher event rate during the post-op period. In the cardiac surgery setting, the risk of cardio and cerebrovascular events are also increased. In this meta-analysis, they not only show that MACE and AFib risks, cardiovascular cerebral events were increased, but also post-op atrial fibrillation risk is also elevated. So anesthesia field very much cares about OSA these days. It's one area where malpractice litigation occurs, partly because it has to do with difficult airway and potential unwanted incidents. There is a Society of Anesthesia and Sleep Medicine, and in fact, there are several people that I'm aware of who are anesthesiologists who are also trained and board certified in sleep medicine. But in this society aims to promote and the awareness in the community about the implications of sleep apnea in the perioperative setting. So why does cardiology should care about this? Cardiology is heavily involved in any type of acute care settings, in the ICU. We heavily deal with patients with respiratory failure, and we often involve ourselves in procedures that involve moderate sedation and sometimes deep sedation, and that puts them at a risk for developing these type of cardiorespiratory complications I just mentioned. Let's talk about some paradigm shift. So for the past 5 decades, the field has been using the same dogma in terms of OSA assessment. In these 2 patients, this is from home sleep study, they have similar apnea-hypopnea index that you may be very familiar with. This is kind of a holy grail index that clinicians typically refer to diagnose sleep apnea, but also grade the severity of sleep apnea. These 2 patients have very similar AHI, but take a look at this oxygen saturation. On the patients on the left, marked desaturation. You can easily see that this patient has probably more severe, profound obstructive sleep apnea than this patient on the right side, where oxygen saturation is not very, it's very mild and not very noticeable, in fact. And so, you know, that just gives you an example of illustration that the AHI may have some pitfalls and limitations. I am very interested in looking at blood pressure change within sleep. So of course, when you talk about this blood pressure at night, people often think of dipping versus non-dipping, and we know that non-dipping is associated with adverse cardiovascular outcomes, and recently that has been highlighted in multiple consensus statement papers. Herein, I'm really referring to sleep apnea-specific blood pressure surge. This itself is not totally known. People are aware, and as I mentioned in my pathophysiology slide, sleep apnea episode is associated with a sympathetic surge that can be manifested as increase in blood pressure. So in this particular example, I used a device that measures blood pressure in beat-to-beat fashion. In this patient, there is a significant marked blood pressure surge following sleep apnea event. But of course, that is very variable, highly variable. Even within a given individual, in a given night, the severity of blood pressure surge can be variable. So this is well kind of depicted in this figure where we collected about 1,700 events out of 17 patients who underwent sleep studies with this device, where we were able to collect beat-to-beat blood pressure measurements. See that this axis is the amount of desaturation. This axis is the amount of blood pressure surge. This height axis is just number of events. You can see that it's highly variable in this, as depicted in this 3-dimensional histogram. this forms a basis for a study that we are conducting right now in this NIH-supported study. We are very interested in looking at whether nocturnal beat to beat blood pressure that is sleep apnea related tell us anything useful about the impact of CPAP on subclinical cardiovascular outcomes. Here we are focusing on the mechanics of left ventricle and left atrium. Some other metrics that I'm very interested in, one of which is what we call the lung to finger circulation time, where we are measuring time interval from the end of apnea to the nadir of oxygen desaturation. Conceptually, it can be described as an oxygen transport time, even though probably that's not the correct interpretation. But this is well described in patients with heart failure and central sleep apnea, where the circulation time is prolonged. In the setting of obstructive sleep apnea, or in the setting of people who don't have any obvious evidence of heart failure, this lung to finger circulation time is still informative. In this study, in this cohort study of using Mr. O's cohort, we demonstrated recently that people who have higher lung to finger circulation time, but without any obvious evidence of heart failure, had a higher incidence of mortality, all-cause mortality, as well as cardiovascular mortality when they were followed up prospectively, alluding to a possibility that this may be another marker that may be useful in predicting adverse outcomes in people with some degree of sleep apnea, because you need a sleep apnea to measure this time. Using this concept, I did some experimental observational study where we experimented on breath hold method, and subjects or patients, I should say, who were undergoing right heart catheterization were asked to hold their breath for about 20-30 seconds. About 2/3 of them manifested desaturation. About 1/3 did not manifest desaturation. A lot of these patients were heart failure patients before right heart cath procedures. We correlated this circulation time induced by breath hold with the invasively measured cardiac output and either FIC or thermal dilution. There was a moderate correlation. The R value here was about 0.56. Inverse correlation, suggesting that this breath hold induced circulation time may be a useful marker or metrics that can give us some information about their cardiac output as well in people with heart failure. Hypoglossal nerve stimulation has come to the main stage of sleep field in the past decade because of the innovation. This device that's implanted in the chest under the skin. The electrical stimulation occurs on this node that wraps around the hypoglossal nerve branch. So implanted by an ENT surgery. When they sense the breath, they can stimulate this in the hypoglossal nerve, whose role is to improve the upper airway and move the tongue out of the way. The airway has been shown to be effective in treating sleep apnea in a STAR trial, and it's FDA approved for the past at least 4 to 5 years, and is currently marketed to use for people who have sleep apnea but can't tolerate CPAP therapy. Based on a similar concept, I'm very interested in looking at the impact of ultrasound on the sleep apnea. And this is work under development. We have shown in preliminary study, we have shown that focused ultrasound may be able to stimulate some of these upper airway muscles through hypoglossal nerve and potentially have a positive impact on sleep apnea. This is another therapy that I'm very interested in, and positional therapy, where people, as we modify their position of sleep, we may be able to improve their sleep apnea as well. Case 2, 53-year-old woman with history of a complex past medical history with morbid obesity of BMI of 47, with a recent admission to outside hospital with shorter breath, is presenting to our hospital with another shorter breath spells. She's on Bumex, OxyContin. Her vital sign shows desaturation. Her past echo showed reduced EF of 40%, moderate RV enlargement. Venous blood gas showed hypercapnia. CTPE was unremarkable. Patient was placed on bi-level PAP, but had to be intubated due to work of breathing. Initially, MICU team was involved, but then when they found that patient does have heart failure, patient was admitted to cardiology team. Aggressive diuresis took place. She was finally extubated on day 2, placed on intermittent bi-level PAP, lost some weight. Venous blood gas shows some improvement in PbCO2. Bicarbonate, however, somewhat worsened, attributing to potential effect of diuretics. On day 3, repeated echo basically showed the similar findings from prior echo, where the LV function was reduced globally, RV was dilated. What is obesity hypoventilation syndrome? This was first, the classic patient is somewhat described by this Pickwick paper by Charles Dickens, referring to this fat boy Joe who always falls asleep and snores. And this was conceptually adopted by this paper and published in 1956, and basically naming it after this Pickwick paper, Pickwickian syndrome, where it describes obese patients who snores loudly and who have severe daytime sleepiness. Essentially, this is the first coining of this term, obesity hypoventilation syndrome. This is the diagnosis of exclusion. You need to have an obesity, you need to have a chronic hypoventilation, but we need to exclude other causes of hypercapnia, such as neuromuscular disease, chest wall, or any parenchymal lung disease, such as obstructive airway disease or interstitial lung disease. Obesity hypoventilation syndrome is typically noted first in the acute care setting. When do we suspect obesity hypoventilation syndrome? When patients are repeatedly hospitalized with acute respiratory failure and in the setting of severe obesity. In the outpatient setting, sometimes this can be hinted by low oxygen saturation on room air. You measure their vital sign, their SATs are 91, 92%, 92%. They don't have any complaints of shorter breath, but you just noted that their saturation is a little on the lower side. We'll skip the pathophysiology. It's actually very complicated. We don't fully understand. It's not just a mechanical component, but there's possibility of a decreased respiratory drive. What is the consequence of obesity hypoventilation syndrome? Associated with a very high mortality, and from cardiac perspective, they're at increased risk of pulmonary hypertension and increased ICU hospitalization, intubation, and post-op complications. About 2/3 of people officially diagnosed with OHS will have some degree of pulmonary hypertension and also associated with RV dysfunction. And left side heart failure is also not uncommon in these patient population, especially HFpEF. Now, good news is that there's some evidence that when these patients are placed on PAP therapy, their mortality may be reduced. In this meta-analysis, they showed that people who are discharged on PAP therapy may have favorable outcomes. This is a figure that was depicted by Dr. Massa, who is one of the experts in the world in Spain. The concept of OHS management is very well depicted here. So nocturnal PAP therapy is the most important therapy, but of course, weight loss and other lifestyle factors is very important, though very difficult to achieve. And with these type of management, their hypoventilation improves, and pulmonary hypertension can also improve. In this recent randomized controlled trial by this group, published in Lancet, Pickwick trial, their question was whether CPAP versus non-invasive ventilation, such as BiPAP, matter in terms of the outcome. Essentially, they showed that there was no difference between the two modalities in terms of the outcome. One would typically think that BiPAP is probably more effective and actually makes sense because you assist with their ventilation in the setting of hypoventilation. But in this study, they showed that CPAP does equally a good job in improving PaCO2 and also reduction of the outcome. Patients with OHS typically are seen in acute care setting, but also in an outpatient setting, often noted in sleep clinic, because sleep hypoventilation typically precedes daytime hypoventilation. So sleep physicians are at the forefront of diagnosis of OHS. Some of the challenges of OHS management is that many patients are not seen by sleep physicians for obvious reasons, and they're in the community, and a lot of patients are in fact seen by cardiology because of their comorbidities. Setting up PAP therapy in the hospital setting is extremely challenging, as a lot of you have experienced, and follow up these patients are not easy. Also, the ownership is not very clear because these patients who I presented in my case, where they typically present with acute and chronic respiratory failure in the acute care setting, they may involve sleep or pulmonary medicine or other specialty, but typically they are lost in this type of setting, and they not only have this hypoventilation issues, but they often have narcotic uses because of pain. A lot of patients are on pain medications because of musculoskeletal issues. They also, a lot of them have psychiatric issues. They're on CNS medications that often worsen the situation in terms of hypoventilation. Some of the pitfalls in the management of OHS, especially pertinent to our discipline, is the fact that many people who have OHS are given excessive diuretics because oftentimes they accompany heart failure as well. So rightly, they're given diuretics. However, this has a potential to create more problem by inducing worsening of metabolic alkalosis, which can blunt the ventilatory response and can worsening of hypercapnia. And this is described by some of the experts in the field, but it imposes a significant challenge in managing these patients. So in summary, OSA is associated with a cardiovascular disease, but treatment benefit of OSA in terms of CVD reduction remains uncertain. Benefit of OSA treatment on atrial fibrillation is still unfolding. OSA increases the cardiorespiratory risk in the perioperative setting. Obesity hypoventilation syndrome is underdiagnosed, but is associated with high mortality. Now, PAP therapy does improve outcomes, and CPAP can be the first line of treatment versus bilevel PAP, and this simplifies perhaps the management to some degree. However, coordination of PAP therapy in compliance is still very challenging. Obstructive sleep apnea assessment requires some paradigm shift, and I gave you some highlights of that, at least from as related to my research interest. And we are in a desperate need in terms of developing novel therapy. As you know, CPAP is an effective modality of therapy, but is poorly tolerated in many of our patients. I'd like to acknowledge some of the funding agencies and all the collaborators that I've been benefiting from. So I'll end here and welcome any of your comments and questions.
Thank you, Young, for that wonderful talk and sharing your insights with us. So I'd like to open this up for questions now. Reminder to the audience to please type your questions either in the Q&A box or in the chat box. We'll get to them both. Or you can also, of course, raise your hand as well, and we could unmute you to ask your questions. We have a question by Nazem. Nazem, do you want to ask your question yourself? Can we unmute Nazem?
Yeah, hold on 1 second.
I see his name.
No, for the sake of time, I can try to address David.
I can. Why don't I go ahead and ask David's question then while we're trying to unmute Nazem. So David asked, have there been any attempts to incorporate OSA into commonly used perioperative risk stratification tools, such as the RCRI?
Excellent question, David. Despite these many studies and evidence that obstructive sleep apnea is a potential risk for in the post-op or perioperative settings, I don't think that has been incorporated into such. Of course, many individual healthcare institutes employ some form of a system where they will tag people with obstructive sleep apnea, trying to alert clinicians about the potential risk, but it's not formally integrated into any type of scoring tools. And of course, one may argue that we may need a study to support that type of direction. However, I would argue, and you may have your own opinion, that it may be a good idea to incorporate this. Even if the risk prediction may not be additionally increased, it is pretty. In our clinical experience, we know that people with sleep apnea has much higher risk of complications. Therefore, I think it's very important.
If we're unable to unmute Nazem, I'll go ahead and ask this question. So Nazem says, great talk. Can you comment on the diagnostic accuracy of sleep testing? Can you underestimate or overestimate severity of OHS with a single night study? And what impact do sleep aids have on OHS?
I'm sorry, what was the last part again?
What impact do sleep aids have on OHS?
Okay. Excellent question. So first, let's tackle the second question first. The sleeping aids that we prescribe commonly in the any type of sleeping aids, there is a risk of worsening obstructive sleep apnea as well as obesity hypoventilation syndrome. In particular, narcotic agents, the opiates, are known to exacerbate hypoventilation, and oftentimes patients who come in with acute respiratory failure are on these medications, sometimes making it a little complicated to diagnose OHS. But I would like to highlight that the OHS, even though it's a diagnosis of exclusion, it can coexist with a lot of other conditions, including COPD. But just to answer your question, yes, definitely it is increased. Narcotics is also associated with essential sleep apnea, but it's very difficult to address this part of the question because in practice, a lot of these patients require these medications to mitigate their pain and for better pain control, but it is certainly making it challenging, making the management more challenging. To tackle your first question, another very excellent question, Nazim. about the accuracy of sleep apnea evaluation. I can probably give you a talk about this around this topic another separate hour here, but the major pitfall of this is that the reliability of AHI is very poor, especially in people with low AHI category. They're easily in and out of that diagnostic threshold. One night they may be called to have sleep apnea, another night they may not have obstructive sleep apnea. So what is it? We deal with this all the time in practice, and it drives everyone crazy. Now, this is why it's very important to consider their symptomatology into consideration. There's a lot of evidence that in fact, presence of symptoms is really important in defining sleep apnea and also in predicting cardiovascular outcomes, and therefore perhaps should be the target of therapy. Now, what is driving this variability? There's lots of different factors, but one major factor I'd like to point out here is sleep position. So if you sleep mostly on your back on one night, you will have high grade of AHI. But if you flip your sleep position to your side, or let's say you sleep on a recliner, because that's what people do a lot of times, especially people with heart failure, your AHI will definitely decrease, sometimes markedly, to the point that you don't have sleep apnea. And therefore, yes, to answer your question, the reliability of it is challenging, and we need some new paradigm to best assess these patients.
Great. Larry Dean says, in regard to David's question, stop bang. This is something new I hadn't heard of. STOP bang is used routinely in the cath labs prior to procedures to assess sleep apnea risk. So that's just Larry's comment in response to David's question. Any additional thoughts that you have on stop bang?
Yes. So thank you, Larry, for that comment. Stop bang is like the most popular one, I think, because of its name. This was developed by anesthesiology group in Toronto. Dr. Frances Chung and her group, anesthesiology group interested in sleep apnea and its implications in perioperative and postoperative management. So it's very well suited to be used for patients undergoing procedures, and it's a fairly quick one, except that to be able to score that, calculate that you need a neck circumference measurement. But other than that, it's a very simple tool. But of course, it tends to overcall people without sleep apnea you overcall sleep apnea in people who don't actually have sleep apnea. Where the negative predictive value is actually good, but positive predictive value is known to be a little poor. But I guess in the acute care setting, certainly it can be very useful to. But I would say that a lot of this is can come as a gut sense. As you. This is why it's important that you go and see the patient. Rather than going through the chart and actually just seeing them in person, an examination can give you a much better, clear picture about their risk of sleep apnea and potential cardiorespiratory risks associated with sedation. So, for example, you will look at their neck size, their overall body habitus, perhaps their mental status. So all these things can be a potentially useful tool for deep learning and or some type of artificial intelligence in providing us a tool to risk assess these patients. So that there's a lot of potential for these.
Young, we have 4 minutes left and a lot of interest and a lot of questions. So I'll try to get through these as fast as I can. Melissa Thompson says, in obesity hypoventilation, are the respiratory muscles hypertrophied Are the respiratory muscles hypertrophied, perhaps due to increased workload like weightlifting?
Very interesting question. I don't think there is any evidence of histological finding of hypotrophy or hypertrophy of respiratory muscles, at least from the studies that I'm aware of, but it's a very intriguing question. Now, one caveat here is that their work of breathing may be slightly increased, but not really. It's a very subtle. In acute care setting, yes, you will see them huffing and puffing in acute distress, but outside of that setting, when they're in the community, it's not very obvious. You will just see them and you'll think, oh, they're just a little heavy breather because of their body habitus, but not more than other people who are comparably obese. What's interesting is that a lot of these patients do not have any complaints. So even though their SATs are low, and they have hypercapnia, if you do an ABG, their CO2 is elevated. Typically high pH CO2 is the most potent stimulant for ventilation, and that's why we maintain our CO2 level very within a very tight range. But somehow, due to metabolic derangement and the chemoreceptor, so to speak, they are not very motivated to ventilate, and that's the most important component of the pathophysiology. And interestingly, that drive actually improves as they reduce their weight. So there's a lot of interesting science behind it.
Chinonso says, do we have any idea of the contribution of contributable risk sleep disordered breathing has for heart disease? What fraction of heart disease is from sleep disordered breathing?
That's an excellent question. I don't think we have been able to tease that component out. In fact, there are only a handful of studies, observational studies, that show that having sleep apnea, obstructive sleep apnea, is associated with increased risk of heart failure. There's only a handful, like 2 or 3 studies that have shown that in the observational study settings. Of course, these were association studies, and we don't know whether incorporating this information about sleep apnea actually adds any benefit to risk prediction of heart failure in general. So, for example, if you add this to a Framingham heart failure score or some type of heart failure prediction score, does it really add to the risk? We don't know. Actually, there's one study that I'm involved. Actually, we're looking at whether OSA does have impact on 10-year pooled risk of 10-year cardiovascular disease pooled risk. So yeah, to answer your question, it is unknown.
A few other questions, but I think we've reached the time. So great talk, Young. Generated lots of interest. Really interesting work. Thank you.
Thank you very much, everyone.